Hello, my name is Laurette Bukasa, and I am a part-time PhD staff student working as a surveillance officer for the Integrated Screening and Outcome Surveillance Service at UCL Great Ormond Street Institute of Child Health. Today, I'm going to be presenting findings from a population-level study on gestational diabetes affecting women living with HIV in the UK and Ireland. Risk of gestational diabetes is increasing proportionally to that of type 2 diabetes globally and is now estimated to affect approximately 16% of all pregnancies worldwide. Current UK guidelines recommend selective screening of pregnant women based on known risk factors for gestational diabetes, and these include ethnicity, family history, and body mass index, which is a measure that uses height and weight to estimate healthy weight. Risk factors are reasonably well understood for the general population, but little is known about risk factors for women living with HIV, and there is conflicting evidence on the effects of antiretroviral therapy. The aim of this study was to understand the characteristics of women living with HIV who had gestational diabetes and some key birth outcomes, and also to investigate risk factors for developing gestational diabetes. This study used data from the Integrated Screening and Outcome Surveillance Service, ISOS. ISOS collects patient-level data on all pregnancies to women living with HIV in the UK and Ireland, but from England only since 2020. Data include HIV infection history, test results, pregnancy, and birth outcomes. Statistical analyses included a multivariable logistic regression model with complete case analysis, including covariates based on chi-square tests. The model was fitted using generalized estimating equations with an autoregressive working correlation matrix to account for multiple pregnancies per woman being represented in the dataset. Sensitivity analyses restricted the multivariable model by time period to prior to 2015 and post-2015 to evaluate the effect of universal antiretroviral therapy on odds of gestational diabetes. 10,553 pregnancies to 7,916 women were reported to ISOS with a diagnosed HIV-1 infection before or during pregnancy, with an estimated date of delivery, EDD, between 2010 and June 2020. These pregnancies were reported by September 2020. Only pregnancies with an outcome at 24 weeks or more were included. Every report of gestational diabetes was considered a case. Gestational diabetes status was missing for 7.6% of pregnancies in the study period, and there was 460 cases of gestational diabetes. Overall, in our population of pregnant women, the median maternal age was 33 years, 72% of pregnancies were to Black African women, and 64% of pregnancies were to women on treatment at conception. This graph shows the prevalence of gestational diabetes over the study period, with error bars corresponding to 95% confidence intervals. In 2010, the prevalence of gestational diabetes was 2.2%. This then increased to 4.7% in 2015, and further increased to 10.3% in 2020, with uncertainty around the 2020 prevalence, a result of having only half the year's pregnancies included. This meant that there was a 2.5% increase in prevalence from 2010 to 2015, and more than double that increase from 2015 to 2020. Overall, 4.7% of pregnancies were affected by gestational diabetes, or 12.8% of those pregnancies to women who had more than one pregnancy affected by gestational diabetes. All results presented here are statistically significant with a p-value less than 0.05. We found that more women with gestational diabetes were 35 years or older and on treatment at conception, with a greater proportion of women of Asian ethnicity affected by gestational diabetes compared to women without gestational diabetes. More women on protease inhibitor-based regimens in pregnancy were represented in pregnancies without gestational diabetes, as well as women with low CD4 cell counts. There was no difference in concurrent infections and HIV clinical status among pregnant women with gestational diabetes and pregnant women without gestational diabetes. We found that stillbirth, emergency cesarean, preterm deliveries, and fetal macrosomia, which was defined as infants born with a birth weight greater than or equal to 4 kilograms, were more common in pregnancies to women with gestational diabetes compared to women without gestational diabetes. In this table, you can see unadjusted estimates and whole population complete case GEE analyses. 93% of pregnancies had complete data on maternal risk factors. You can see here that year of estimated date of delivery is associated with a 12% increase in odds of gestational diabetes. And odds of gestational diabetes was approximately 3 times greater among pregnancies to women aged 35 years or older compared to women under 25 years. Pregnancies to women from Black, African, and Asian ethnic backgrounds were 1.55 times and 2.6 times more likely to have reported gestational diabetes compared to women from white ethnic backgrounds. And this is also consistent with the general population. Pregnancies to women with CD4 counts less than 350 were 26% less likely to have gestational diabetes than pregnancies to women with CD4 counts greater than or equal to 350. Treatment at conception and protease inhibitor use in pregnancy was not associated with gestational diabetes risk after adjusting for other factors. In sensitivity analyses comparing the periods prior to 2015 and post-2015, advanced maternal age and Asian ethnicity remained the only significant risk factors, and ART was not associated with gestational diabetes risk in whole population GEE and sensitivity analyses. Overall, prevalence of gestational diabetes in this study was slightly higher than estimates from a recent systematic review and meta-analysis conducted in 2019 for Europe and America over a similar time period. In the UK, prevalence of gestational diabetes among women living with HIV has increased significantly, even after accounting for an aging population, with advanced maternal age most strongly associated with gestational diabetes, which is not accounted for in current screening guidelines. Limitations of the study include missing data and being unable to account for the effect of weight indices, specifically BMI, on gestational diabetes odds, although BMI is now being collected by ISOS and therefore will be accounted for in the future. I'd like to thank all the respondents who report to ISOS and the ISOS team. If you have any queries, please get in touch, and thank you all for listening.